You are listening to the American College of Cardiology's CardiaCast. Today's discussion is the second part of a series of educational activities that includes 4 CardiaCasts evaluation and management of ATTR CM, which is transthyretin cardiomyopathy. This series is brought to you by the American College of Cardiology Foundation and MedIQ, and is supported by an educational grant from BridgeBio. Keep an eye out for more engaging discussions on ATTR CM coming soon. And for additional complimentary CME and resources on this topic, visit www.mediq.com or acc.org. I'm here today with Dr. Kevin Alexander, who is an Associate Professor of Medicine at Stanford School of Medicine, and who is an amyloidologist. He focuses on the science, treatment, and evaluation of patients with cardiac amyloidosis. And I'm Ahmad Masri. I'm a cardiologist at Oregon and Health and Science University, and I also have a passion and a focus on cardiac amyloidosis. Kevin, thank you for joining us today.
Yeah, thanks for having me, Ahmed. Look forward to the discussion.
Great. So I think what we're going to do today is that we're going to discuss few things that caught our attention during some of the last year's conferences. I think these are more or less updates or new analysis from randomized clinical trials for ATTR CM. As many of you are aware, we now have 3 FDA-approved medications that can be used for transthyretin cardiomyopathy. The first one was tafamidis, and the second one, acoramidis. Both of them are stabilizers. They have unique properties and characteristics, each of them. And then the third one is a silencer, which reduces the production of transthyretin protein from the liver, vutrisiran, that was already initially approved for polyneuropathy, hereditary polyneuropathy, and now is approved for cardiomyopathy. So let's dive in. Kevin, one of the abstracts that, I had the pleasure of presenting had to do with the effects of acoramidis on recurrent and cumulative cardiovascular outcomes in ATTR CM, which was an exploratory analysis from ATTRibute CM. I think one of the things that comes out all the time is that we use different statistical approaches to analyze outcomes in clinical trials. And one of them that was used in ATTRibute was the win ratio, where you are looking at mortality as a comparison between the two arms of acoramidis and placebo, and then you move on to cardiovascular events, and then you move on to other things such as NT-proBNP and 6-minute walk test. However, some other trials looked at the totality of evidence that has to do with mortality and recurrent CV events, and this is what was done in this analysis here, which is trying more or less to do that. Can you share with us a little bit your thoughts about that, maybe some of the results, and what do you think that this changes how we think about ATTRibute CM and its results?
Yeah, first of all, congrats on leading that analysis. I think it's a really important subgroup analysis or post hoc analysis from the ATTRibute CM study. Of course, we all care about overall mortality and therapeutic interventions that can ameliorate or improve that. But particularly as we move to a population of ATTR patients who are less sick, who are going to live longer with their disease now that we have these disease-modifying therapies, one big event that confers a lot of morbidity and potentially downstream mortality are cardiovascular hospitalizations and urgent heart failure visits. And so I think it's really important to understand how an ATTR therapy not only prevents, say, that initial hospitalization, but, going forward, are patients getting multiple hospitalizations? Are we able to kind of stave off that poor prognosticator of having multiple hospitalizations? In my heart failure transplant cardiology hat, when someone's had more than one heart failure hospitalization a year, that's when we start to think about things like advanced therapies such as heart transplant. So clinically, I think it's really important information to understand beyond that first CV hospitalization or cardiovascular mortality event, what happens to patients. And so, I think the data that you presented nicely and then published is that acoramidis significantly reduces the rate of recurrent cardiovascular hospitalizations, and it happens relatively early and quickly. I think the timing of how quickly we see differences compared with placebo is interesting and, kind of warrants its own kind of deep dive into how these drugs work and how they can confer these market clinical benefits so early. So, I think that study was an important complement to the overall main trial.
Great, and I agree. One important thing to remember in transthyretin cardiomyopathy is that patients who tend to worsen continue to worsen, and patients who tend to stabilize continue to be stabilized. And as such, if we only look at the first event there, we might be missing a lot of the burden of the disease. And the other piece of it is that this is a chronic condition. It goes through less and less cycles of congestion, decongestion, or more actually of progressive problem in general. And that's what we see with the hazard ratio over 30 months being almost 0.5. And that's a pretty tight, really, effect of having that effect on recurrent events. I think that is a language that can be used if one is trying to guide discussions with patients for sure. So that was one of the analysis, and it was published in JACC simultaneously at the time with the Heart Failure Association meeting as well. There was another analysis that looked at the effect of acoramidis for patients who have atrial fibrillation or don't have atrial fibrillation. I think one of the things that come up always in the discussion is that almost 60%, if not more sometimes, of patients with transthyretin amyloidosis have atrial fibrillation at baseline. And whether this is a marker of the cardiomyopathy severity itself, whether it's a marker of the heart failure severity itself, and whether that will modulate the response to therapy versus not, has been always an open question. So I don't know if you saw that abstract or not, but Matt Morer presented on this, and so would love to hear your thoughts if you had a chance to review it.
Yeah. I think that stratifying patients without atrial fibrillation is important for us in clinical practice because, like you allude to, atrial fibrillation is quite common among amyloid patients. And I think we're increasingly becoming aware that it contributes a lot to the symptomatology of ATTR patients. Losing the atrial kick, having a rapid ventricular rate in these restrictive cardiomyopathy patients can lead to worsening symptoms, worsening quality of life, and increase the risk of hospitalizations, which we saw in the main ATTRibute trial when you break down the reasons for hospitalizations. So I think looking at how a disease-modifying therapy like acoramidis performs in both groups is an important analysis. And my takeaway from the data that Matt presented was that across both groups, there is a consistent benefit of acoramidis. So, in this analysis, it looks like independent of atrial fibrillation status, we saw benefits in terms of impact on biomarkers, including NT-proBNP, as well as on functional status. I think as we think about the impact of atrial fibrillation on ATTR patients, it's helpful to highlight and understand that there seems to be a benefit, not just in certain subgroups, but pretty broadly applicable benefit.
Totally agree. And I think one of the interesting pieces that are emerging from some of these analyses is that while on average you have stability of the cardiac biomarkers such as NT-proBNP, maybe even functional assessments such as 6-minute walk test, the reality is that there are positive responders where they have reduction in their NT-proBNP and improvement in their 6-minute walk test. And there are some patients who don't necessarily respond as robustly. And then when you combine the whole population, obviously you end up having a treatment effect that is stabilized. The placebo patients continue to worsen typically, but that's another thing to guide discussions with patients. We hear it all the time that patients say, well, am I going to get better? And I know the textbook answer is no, we're just trying to not make you get worse. But the reality is that there are responders, and our understanding of that response level is somewhat still primitive, in my opinion. We don't really know why or how or which patient would respond just by controlling the precursor protein problem in this scenario, transthyretin, for example.
Yeah, I completely agree, Ahmad. And that's probably one of the thematic takeaways I have from this last year of data from the trials we present at the conferences. While I think it's important to counsel patients that the goal is to try to prevent further progression, and you may not feel better, I think giving that message of optimism that some people do get better after starting these treatments and, relatively quickly. So I think that not putting a ceiling on what these, therapies can do is important. And the data that we've had kind of in these recent abstracts supports that.
Great. And then another analysis that caught my eye was an analysis from the HELIOS-B study. Just as a reminder to our listeners, HELIOS-B was a phase 3 registrational trial of vutrisiran against placebo in patients with transthyretin amyloid cardiomyopathy. And in this secondary analysis, what happened is one of our mutual colleagues and friend, Ron Wutelis, presented the effect of having tafamidis in the background. So as a reminder, HELIOS-B was not a study where everyone who came in was on standard of care background medical therapy. There were some stipulations within the trial that only 40% could have been on tafamidis at baseline. There were some limitations in terms of how they felt and maybe progression here or there. It was, not necessarily like defined as a criteria how that would work. But ultimately, it wasn't like everybody could come in on tafamidis. And so the question then becomes, you've had 40% of these patients at baseline on tafamidis. You've had another about 10% or so in total drop in throughout the trial. So that analysis looked at censoring patients when they drop in on tafamidis as part of the trial in an attempt to maybe isolate the effect of vutrisiran there and see if there's any modulation of effect due to the drop in or not of tafamidis in both arms, really, of the treatment arm as well as on the placebo arm. So any thoughts there about these results and what they would mean?
Yeah, and I think this kind of goes along the theme of the comment you made about the last abstract, that when we look at a treatment group, there can be a heterogeneity of response, and you end up getting an average of that response. And so the overall population may look positive, but there could be some subgroups that did really well with the intervention and other groups that didn't have a response. And so certainly something like tafamidis background would be something where we'd want to know how patients, if they're on background or drop in tafamidis, performed with vutrisiran treatment versus those who were not exposed to tafamidis. So I think that it's an important analysis. And then, like you alluded to, the folks that were on background therapy were probably a little bit different than those that weren't, just simply by the fact that this was related largely to access to tafamidis. So in the U.S., during HELIOS-B, we had pretty broad access to tafamidis, whereas other parts of the world did not, such as the UK. And so, there's differences in practice patterns, as well as how patients are treated with adjunctive heart failure therapies, likelihood of being managed in the hospital for heart failure versus, say, as an outpatient. And all these nuances can have confounding effects on the data that aren't kind of necessarily randomized. So I think this was an important analysis looking at the tafamidis censoring. And what Ron presented essentially showed that when you censor those tafamidis patients and really look at a vutrisiran monotherapy population, the treatment effects seen compared with placebo were consistent. So I think reassuring and also very helpful for us to understand that even without vutrisiran, the market effects that we're seeing with vutrisiran appear to persist.
I fully agree. And the more data we can get from these trials, the better our understanding of what exactly happens in subpopulations would be. Just simply because, again, a reminder that we don't have head-to-head trials with these different medications. And so that's really an important piece of it. Switching gears a little bit, there was another interesting abstract that was presented by Yusuf Razvi from the National Amyloid Center in the UK. They looked at about 45 or so patients in the HELIOS-B study that underwent cardiac MRIs at baseline and then again during follow-up. They've had a few years of follow-up, over 3 years. I think one of the biggest issues, I always struggle with the imaging studies where you have a lot of patients who did not end up coming back for the repeat imaging study. Regardless of that limitation, what they've shown is that there is actually an improvement in some of the structure and function markers in patients treated with vutrisiran as it compares to patients treated with placebo. And so I think that's something that we typically don't necessarily talk about. We usually, again, say that we can improve you overall by not deteriorating, but it is not necessarily a common discussion with patients that we're going to improve their cardiac structure and function from baseline. Any thoughts about that abstract and that data?
So first thing I would say is that It's an exciting time in ATTR because we're learning so much from the trials in terms of therapies, but also kind of the natural history and pathogenesis of ATTR. And one of those things is how the heart can respond to treatments and what the dynamics are of amyloid deposition and potentially reversal or regression and how that would work. And I think one component to understanding that would be imaging. And so kind of with the limitations that you mentioned, with a small sample size, I think these study results are hypothesis generating and raise the possibility that we can see evidence of regression of amyloid or improvements in amyloid on something like an MRI. And, perhaps that can help inform us in a real world setting down the road for following patients as our populations grow and we see people longer and longer out. I think the translation to clinical practice, at least in the US, is somewhat of a challenge just because in my routine practice, I don't do serial MRIs in a clinical setting and then kind of the measurements, also, I think there could be some issues around that. But in a pure trial population where we have central readers and, good controls, I think these data are helpful. The other thing that helps inform us with, I think, would be the ongoing clinical trials, particularly the depleter trials, where that mechanism of action is hypothesized to more directly affect amyloid deposition and lead to reversal. So kind of understanding how to utilize imaging modalities such as MR serially, I think it's important. And so the more data, the better. Definitely curious on your thoughts about it, given that you are an imager and spend a lot more time thinking about this than I do. But those are kind of my thoughts.
Oh, great. Appreciate the discussion there. Yeah, I think I alluded to it, is that I like to see more data. It's just I like to see larger sample sizes of these patients, more multi-center evaluation. I think, we've learned this from many other therapeutic interventions that when you have single center trials, you have so many things within your center's practice that influence that treatment effect. Even though it's a randomized clinical trial and you're unaware of the treatment assignment. I can just use a very quick example of what we observed with beta blockers in hypertrophic cardiomyopathy. The single center studies did not resemble what the multi-center larger clinical trial ended up showing. And so this is not just in one example. There are I could pull probably hundreds of examples of the same. And so we always want to, think of this, in my opinion, as multi-center evaluation, because you need to expand that heterogeneity, because only you can really get at the treatment effect by having more variance usually. If you're quashing the variance by eliminating or limiting all the other variables that can contribute to someone's outcome and livelihood, I think that's when you get usually treatment effects and sizes that it's very hard to replicate. Plus the challenge that we all struggle with in imaging, which is if you don't come back for the image, we have to impute, your results either by having them missing at random or by assigning the worst outcome, which is not always necessarily true for everybody. If you die, for example, are you really the worst 10% of the findings? I mean, if you die, maybe you should be really, really, bad in terms of progression. So all of these things need still, something worked up. I want to switch gears to another biomarker that actually is somewhat becoming slowly a favorite of mine, even though we need so much more data on it. But I think its simplicity speaks really volumes. It's serum transthyretin. ATTRibute CM have helped us really understand a lot about serum transthyretin, and really kudos to the steering committee and the group there that are continuing to put out data from serum transthyretin. There was an analysis by Dr. Sarswat showing that change at week 28 is associated with outcomes, and that's just the earliest that they measured that change in ATTRibute CM. And those data were pretty actually impressive when you look at these outcomes over the follow-up duration. And so a few questions. One, what are your thoughts about this? And two, are you using it in your practice? Just to probably like me, to understand really what goes on with these patients.
Yeah, I think it's a interesting story that's developing. The fact that we've observed that with stabilizer treatment, that serum TTR increases, and probably has somewhat to do with the decreased breakdown of serum TTR. I'll give the caveat that I'm not a biochemist and won't go into the weeds about TTR stabilization and the monomeric fraction versus tetrameric, but the simple association or observation that stabilizer treatment leads to increases in the serum TTR, I think is well established. And in the ATTR CM study, there's been several nice studies that have shown that association with that increase from baseline to day in the first month, for every milligram per deciliter increase is associated with the reduction in cardiovascular hospitalization. So, as a clinician, that's just a very tangible finding. Like you said earlier, patients often ask, how do I know the drugs are working? Well, if you measure this before and after you start acoramidis, you can say, well, these are what the study data show. And I think the other interesting thing, when these data are broken down into the wild type and variant populations, variant patients at baseline have a lower serum TTR compared with wild type. Both groups have an increase in serum TTR with acoramidis treatment, and that variant group, which starts out lower, ends up having an average serum TTR similar to wild type. So they almost kind of catch up. And we know from the subgroup analysis in that variant population that the effect of acoramidis is consistent with wild type. So I think it's a complementary piece of data as we try to understand other endpoints and trials. But specifically in clinical practice, to answer your second question, I do measure it. What to do with it, I'm still learning. But I think with a space like ATTR, where it's dynamic and we're still understanding a lot about the pathogenesis of the disease, I believe it's better to collect data as you go so that you have the ability to collaborate with yourself and other folks to pool that data together and kind of learn from our real world experience. So I would say that I measure it in clinical practice. Patients, they get their lab results as fast as I do on their phones now. So it's something they can look at and see that their serum TTR levels rise with treatment. And I guess I would say in those rare cases where I don't see a rise in serum TTR, say after starting a disease-modifying treatment, that probably, raise a little antenna that, is there something going on here in terms of maybe in that individual patient, there's less of a response. And so I'd probably watch them more closely clinically, based on that.
Very well said. Few things to remember, I think it's worth for our listeners, is that stabilizers are meant to increase the transthyretin level because they stabilize the tetramer form and try to make it break down less, while silencers like vutrisiran are meant to actually lower the secretion of transthyretin from the liver, from the hepatocytes, and so you're expected to have less serum TTR. Some people start thinking, well, how can you have beneficial effect of two opposite things? It's really not two opposite things. You're just really dealing with the precursor protein, one by preventing it from coming out from the hepatocytes. The other one is just by preventing it from breaking down and stabilizing it. So you got to just put this into context. And then the other point is, for serum transthyretin to be useful, you need to do it in an outpatient settings when patients are not sick because it's a negative acute phase reactant. So if you're only doing its evaluation when someone is ill, it's really not going to work out, at all. And you will always find the usual finding, which is, lower serum TTR is associated with worse mortality because that's what you're observing. You're observing that people who are sicker have lower serum TTR. So that really doesn't work. You need to do it more or less in patients who are, stable outpatient over a relatively reasonable period of follow-up, not like, for example, 5 years later and they've lost weight and they're much older now and there are other things that are, going on with them. So fantastic. I think we have a few minutes left. We like to cover probably the last topic of the day, which is quality of life. There's a lot of focus on mortality, heart failure, hospitalization, cardiovascular events. We've seen a lot of quality of life from ATTR CM. Here we've had some presentations from HELIOS B on baseline quality of life and how does that influence response of patients to therapy and how they feel in terms of their quality of life. If you don't mind sharing your thoughts about, that poster that was presented that looked specifically at the effect of vutrisiran based on the patient's baseline health status and quality of life.
Yeah, but I think that quality of life is an important variable to consider in ATTR patients. I'd keep in mind that a lot of our patients are elderly. The median age in these trials is mid to late 70s. And so I think that what's important to an 80-year-old, for example, in terms of outcomes is different than a 50-year-old. And so I think the older folks get, the more that quality of life matters, let's say the absolute longevity. And so looking at these outcomes in the ATTR trials is important. The vutrisiran abstract that you mentioned looked at patients stratified across different KCCQs and high and low KCCQs. I think KCCQ has been well validated as a patient-reported outcome in heart failure studies and has been shown to respond to treatment and differentiate from placebo in trials. It can be pretty dynamic with differences being seen within months. So I think that with the vutrisiran subgroup analysis, it showed that there was benefit slowing down that KCCQ worsening compared with placebo, so that's important to know. And kind of going back to relate a little bit to the discussion we had around serial imaging, I think one nice thing about KCCQ is that it is relatively easy to perform. You could implement it in clinical practice. It's standardized. Alexander here at Stanford did a heart failure study where this is data collected before the clinic visit and shows up in our EHR as a variable. So we can trend it like other result tabs. It shows up when we walk in to see the patient. And one of the things I think it helps me with when I have that information is that it's kind of another quality check that when you're evaluating a patient that you're understanding, how they're feeling. Some patients are more expressive than others. And so if I look at a patient and they say, oh yeah, I'm feeling pretty well, but then you look at their KCCQ and you see that it's dropped and you see kind of what those complaints are, it can hone in and say, hey, well, you say you're feeling well, but tell me about, this shortness of breath or this limitation that you're describing here. And so for me, it can help to make sure that I'm not missing anything in terms of someone that's not doing as well. And, we haven't talked about it much today, but I think one important thing, in addition to these disease-modifying therapies or all the other things that we do for ATTR patients with their heart failure management and rhythm control, et cetera. And so changes in quality of life oftentimes will prompt me to make sure that we're not missing anything, beyond the disease-modifying therapies.
Definitely, and I think it's really important to remember that these patients are living with transthyretin amyloidosis, but there are other factors that can affect how they're doing and what's going on. Recently we've had a viral infection that's been, circulating around. I'm not so sure which actually virus exactly, since the viral panels are generally negative. But we've had few patients who had really worsening of their heart failure status. And I think, the common themes that you can pinpoint it back to when they essentially had severe viral infection, systemic symptoms, upper respiratory symptoms. And so it's not necessarily always that when someone is getting worse, that means that they're getting worse because the underlying disease itself is progressing. People live with many different issues, and one needs to isolate what is the exact culprit or cause of them, feeling worse or getting worse. The other point that essentially is of a struggle, I think that to me, the delta change in KCCQ is more useful to think through studies compared to like the baseline values. As you know, both of us see a lot of patients with different diseases, not just amyloid or transthyretin amyloid. We see some patients who are very sick with light chain amyloidosis, other patients with other cardiomyopathies. And it's always amazing to me how the transthyretin patients technically are optimistic in how they essentially score actually themselves on the KCCQ. So you end up seeing relatively high values for these patients. In the HELIOS B study, for example, the majority of patients had a KCCQ above 50 with an average baseline probably in the late 60s, early 70s, which is, if you look at across these other trials for other diseases, that can be even better than many of these other diseases. And I think part of it is that as you get older, your expectations of what you want to do or can do essentially become less and less. So I think, for our listeners, again, one has to really place this within the context of this trial. I am not 100% sure that quality of life scores are transferable and can be, directly compared head to head across different diseases, different subgroups, different scenarios. I think it's more or less what you're looking at is the placebo-corrected change in these metrics. I don't know if you agree or not.
Yeah, I think it's a great point. I mean, I think about that and heart failure at large. Well, I mean, this even goes to things like NYHA class, what's important or what's an acceptable quality of life and or functional status is very different in an 80-year-old than it is a 40-year-old. And so being able to walk around the grocery store may be acceptable to someone that's 80, someone my age, if that's all I could do, probably would not be as, happy with that. So I think that patient-reported outcomes are extremely contextual, like you're alluding to. And so I think we have to kind of keep that in mind and also refrain from making large cross-trial or cross-disease comparisons.
Great. And then I think we'll end on this final point is that now we have 3 medications that are available, as we discussed initially, in our practice. There are no head-to-head trial comparisons. I do believe that if you are treating patients with transthyretin amyloidosis and you want to think through this, I think it's mainly at this stage shared decision-making with the patient. But you do need to study this at a deep level, understand the performance and the behavior of each of these drugs within these subgroups. This, I think, will allow you to make up your mind and decision of how you want to approach this. But we're far, far away from saying that a first-line therapy should be X, a second-line therapy should be Y. And, moving between these classes is very reasonable when you think that the patient is progressing with their underlying disease. Anything to add there from like a clinical pearls perspective?
No, I think that's all well said. So, yeah, clinical pearl. I mean, I guess I would just reemphasize the shared decision-making is extremely important, I think, with our current data landscape. The second thing I would say is that there's going to be these questions about what, sequencing of therapies or combination, et cetera. Randomized trials are only going to give us some of that data since none of these are going to be compared in a 3-way randomized controlled trial, for example. So we'll have to lean on our real-world experience. And hopefully we can collaborate amongst a number of centers to follow these patients as they've been on different therapies and switches over time. Because I think that'll be the level of evidence that we'll have available to help us going forward.
Great. Very well said. Well, thanks to all of you out there for joining us today. Thanks to Dr. Alexander for joining us today. As I mentioned in the beginning, this activity is part of an educational series provided by the American College of Cardiology Foundation and MedIQ, and supported by educational grants from BridgeBio. Keep an eye out for more engaging discussions on ATTR CM coming soon, and for additional complementary CME and resources on this topic, please visit www.mediq.com or acc.org. Thank you.